So there's a high burden is a leading risk factor for cardiovascular disease and chronic kidney disease, and the prevalence is increasing in lower middle income countries. The recommended thresholds for treatments is also changing. So traditionally, hypertension was defined as a systolic blood pressure of 140 or more and a diastolic blood pressure of 90 or more. However, more recently, the American College of Cardiologists and American Heart Association 2017 guidelines recommended treatment for systolic blood pressure above 130 and diastolic blood pressure above 80 for people with CVD or high CVD risk. And in the WHO, although they did not change the threshold, they do recommend treatment now since 2021 for a systolic blood pressure above 130 for people with diabetes, CVD, and high CVD risk. However, we do have some data limitations. There's limited national data on all adults in Sri Lanka, that means including people above the age of 69. And we also have somewhat limited analysis of subgroups of people in nationality. So the aim of our study was to assess the prevalence of hypertension in a full adult population using both the standard threshold of 140 on 90 and the ACC-AHA threshold of 130 on 80. The study was published in Global Heart last year, so you can have a look at it if you wish. So the data we used is from the wave 1 of the Sri Lanka Health and Aging Study, where we collected data from November 2018 to November 2019. The blood pressure was measured, we had 2 measurements, and we took the average of these 2 measurements. It was measured after 10 minutes of rest. We used an Omron monitor for this, and a key point is that we used a cuff that could measure people with very skinny arms and people with larger arms. So the same cuff could do that, which is important because people with larger arms, if you use a small cuff on them, they would get a higher blood pressure and you would overestimate the prevalence of hypertension. Medications use was recorded for the past 14 days, as Prasadini discussed, and we also measured the height, weight, and waist circumference. So we were very particular about what instruments we used so that we could get reproducible results. So moving on to the results, we had data to estimate the prevalence from 6,342 individuals from 298 primary sample units. So this is 95% of our survey sample. The mean age was 49.9 and 51% of the participants were female. So we had a good male-female balance in our sample. And as mentioned before, there was some underrepresentation of younger adults and Muslims, Moors, and Malay people. But when we used weights, the final weighted sample matched the Sri Lankan population in age, sex, ethnicity, area, socioeconomic status, and household socioeconomic status. So this is the prevalence of hypertension in Sri Lanka using the standard threshold. The overall prevalence is 28.2%. So just under 1 in 3 adults in Sri Lanka where we plot the prevalence. Where we plot the prevalence of hypertension by age for men and women. For men and women, what we can see is we have a very rapid increase in hypertension prevalence from the ages of, say, 30 to 50. And the increase is even more rapid in women than men. We see a similar pattern, but with a higher prevalence rate when we use the 130 on 80 threshold. And when we look at our Sri Lankan map, we can see a wide variation in the prevalence of hypertension by district. So approximately 1 in 3 adults in Colombo and Nuwara area had hypertension using the standard threshold, whereas districts such as Kilinochchi, Murugyu, Trincomalee and Ampara had less than 1 in 5 adults with hypertension. So let's have a look at the breakdown by different subgroups of people. So if you look at the prevalence using ethnicity, we can see that people who identify as Muslim have a slightly higher prevalence than the Sinhalese people. And if you look at education levels, there's a very obvious pattern where people with less education have a higher prevalence of hypertension. There's also a high prevalence of hypertension in people living in urban areas and rural areas. So 45% of people in urban areas have hypertension. When we look at socioeconomic quintile of the households that our participants lived in, there is a general trend where richer households, people from richer households had a higher prevalence of hypertension than people from poorer households. And if you look at the area that they lived in, so the primary sampling and the socioeconomic tertile that area has, the people living in more developed areas were having a higher prevalence than people living in less developed areas. Again, there's a trend by BMI. So people with a higher BMI have a higher prevalence of hypertension. So there's 40.6% of people with a BMI above 30 has hypertension. And more than half of the people who have been diagnosed with diabetes have hypertension. I just want to take a quick minute also to talk about DEF, or the design effect. So what the design effect means, it measures the impact of survey design on data variability and calculation of sampling error. So compared to random sampling, cluster and stratified sampling can lead to an increase in variability of estimates because of possible similarities of participants that live in the same cluster. So DEF is a simple ratio which really just compares the actual sample size in, say, in our study to the sample size that if you use random sampling, that would yield the same precision. So if you had random sampling, you randomly picked people totally randomly in the country, you would need a smaller sample size than if you had with cluster sampling. So if you have a DEF above 1, it means that the actual design has increased the variability through sampling error. And if it's exactly 1, it means the actual design has no effect on variability, so similar to randomly sampling participants. So the typical assumption is that in many hypertensive surveys is that the DEF is between 1.5 to 2. But we had a look at the DEFs in other hypertension surveys around the world, and we had to manually calculate some of them because they're not always published. And in the South Asian and Sierra region, the mean DEF of the hypertension surveys we could find was actually 7.3, so it was quite high. The median was 3.6, and it ranged from surveys, so between 1.5 to 22.2. Even the NHANES in the United States has a DEF of greater than 5. So our SLHAS DEF was 1.79, so quite low. And what we believe is our design elements would have helped to reduce the DEF. So to sum up the main points, the prevalence of hypertension in adults in adults in Sri Lanka is higher than previous estimates at 28%. It's far higher than what is reported by the NCD Risk Factor Collaboration estimates for Sri Lanka. People who need treatment the number of people who need treatment may be higher than initially thought. So using the ACC and AHA definition increases hypertension to